afternoon, everyone, and welcome to today's Public Health Ontario Rounds presentation entitled Spread Awareness, Stop Resistance, Antimicrobial Stewardship Amid the COVID-19 Pandemic. My name is Brad Langford, and I'm a pharmacist consultant with the Antimicrobial Stewardship Program here at Public Health Ontario, and I have the pleasure of moderating today's presentation. Before we begin, I'll mention a few housekeeping items. Firstly, the chat pod has been disabled to limit any distractions during the presentation, but you can use the Q&A pod if you have any questions during the session. And there will be a question and answer period following the presentation. If at any point during the session you experience any technical issues, please email capacitybuilding@oahpp.ca. And as the moderator of this session, I would like to declare that I have no potential conflicts of interest. Next slide, please. So this presentation marks the second last day of World Antimicrobial Awareness Week. Antimicrobial Awareness Week is a global campaign to promote the judicious use of antimicrobials to prevent the emergence of antimicrobial resistance and keep antibiotics working for future generations. So one of the activities for World Antimicrobial Awareness Week is to make antimicrobial resistance more visible by using the color light blue. And this has been a color that is designated by the World Health Organization to represent the global impact that antimicrobial resistance has on the people, organizations, and communities, and also to recognize those people, organizations, and communities have the power to address this growing public health threat. So ways that you can support on November 24th, which is tomorrow, the last day of Antimicrobial Awareness Week, include wearing light blue, incorporating light blue into your social media profile, and explaining to your family, friends, and colleagues why you are going blue for antimicrobial resistance. And for those of you who are in Toronto, the CN Tower will turn light blue on the evening of the 24th in support of World Antimicrobial Awareness Week. And if you're not in Toronto, you can check it out online via the webcam. If you're looking for any further information about Antimicrobial Awareness Week to share with healthcare professionals or the general public, please check out antimicrobialawareness.ca. Next slide, please. So our objectives for today's session are to explain the impact or the potential impact of COVID-19 on antimicrobial resistance. We'll explain our rapid review findings on bacterial co-infection and secondary infection in patients with COVID-19. And we'll also discuss how the pandemic has impacted antimicrobial stewardship programs, both globally and within Ontario. Next slide, please. So to start the presentation, we have a couple of polling questions. So if you can bring up the first poll, Lydia. So this question asks, which of the following factors could increase the rate of antimicrobial resistance during the COVID-19 pandemic? And this is a single choice, multiple choice question. So if you think that there are multiple responses that are correct, you may be right, but check the one that you think is the most correct. And I'll give you a few seconds to complete that poll. Maybe another 5 more seconds or so. Okay. And so the vast majority of people have selected antimicrobial use as a key factor that could increase the rate of antimicrobial resistance. So great. Next slide, please. So this question asks, what is the percentage of patients hospitalized with COVID-19 that also have a bacterial co-infection? Is it 1%, 5%, 15%, or 33%? And I'll give you about 20 seconds or so to complete that poll. Great. So there's a split response here between, it looks like actually kind of split between 5% and 15%. So not to spoil the punchline at all, but these questions we are going to delve into in today's presentation. So with that, next slide, please. It's now my pleasure to introduce the speakers for today's presentation, Miranda So and Valerie Leung. Dr. Miranda So is a pharmacotherapy specialist at the Sinai Health System University Health Network Antimicrobial Stewardship Program. Miranda teaches the infectious diseases and antimicrobial stewardship curricula in her role as assistant professor, status only, at the Leslie Dan Faculty of Pharmacy at the University of Toronto. Miranda is also a clinician investigator with the Toronto General Hospital Research Institute, and her research interests focus on antimicrobial stewardship in immunocompromised patients, specifically hematology oncology and organ transplant recipients. In addition to the use of technology in health profession education, her research also expands to antimicrobial use and population health. And our next speaker is Valerie Leung. Valerie is the Antimicrobial Stewardship Program lead at Public Health Ontario, where she works with a multidisciplinary team and external partners to advance antimicrobial stewardship across the healthcare system. Valerie is also a clinical pharmacist at Michael Garron Hospital in Toronto East Health Network, where she is involved in local quality improvement initiatives. So with that, I will turn it over to Miranda to get us started.
Thank you for the opportunity to present today. I'm presenting on behalf of Taran, which I'll explain in a few moments. So where are we at in terms of the COVID-19 pandemic thus far? The events leading up to March 2020 are well known. Thankfully, since then, major advances have been made in terms of treatment and prevention of COVID-19. If you don't mind, Val, can you click through, please? Nevertheless, unfortunately, we are currently in wave 4 of the pandemic. Next slide, please. Very early in the pandemic, there had been lots of discussions about whether COVID-19 would increase or not the antimicrobial resistant rates worldwide. In this pro-con debate published in the journal JACAMR in July of 2020, concerns about the rising of antimicrobial resistance were supported by early reports that the prevalence of bacterial co-infections were actually far lower than the prevalence of antibiotic use amongst hospitalized patients. Some of that could be related to the demographics of the hospitalized patients early in the pandemic, but also related to the diagnostic challenges in identifying bacterial co-infections and the ensuing empirical use of antibiotics. Now, countering those arguments were others who felt that with improved infection control practices, a reduction of non-COVID respiratory infections, such as seasonal influenza, as well as public health measures, such as restrictions on travel and gathering, it will not result in an increase in antimicrobial resistance prevalence. Next slide, please. Since then, others have contributed to this discussion. And some of the key points that I will highlight here include the availability and uptake of vaccine against COVID, public health measures, the postulated impacts of the public's behavior and their access to healthcare, the effectiveness and adverse effects of COVID-19 therapy, particularly with the immunomodulatory therapy, in-hospital infection prevention measures, but also the collateral damage on non-COVID related healthcare services, as well as the impact of the pandemic on human healthcare capital, such as redeployment and burnout of healthcare professionals, as well as the structural resources available within the healthcare system that have been stretched to their limits. Next slide, please. Now, in my mind, to help me understand the interplay between COVID-19, bacterial infections, antibiotic use, and resistance, I put it down here in a graphical representation of the various contributing factors, but also countering factors in this causal diagram. So to understand the relationship between COVID-19 infection and antibiotic resistance, maybe I could walk you through a few steps. The patients with COVID-19 might have different levels of exposure to healthcare system. Maybe they're treated as outpatient instead of inpatient, especially with the availability of virtual care. But patients who were admitted or those requiring very invasive supportive care might have different exposure to bacterial infections as well as nosocomial pathogens. And with that, they might be exposed to antibiotics to different levels, and therefore emerging antibiotic resistance, the risk might also be different. All of this might also be confounded by the use of COVID-19 treatments that might have an impact on the immune system that might predispose them to bacterial infections and thus antibiotic exposure as well as resistance. On the other hand, in institutions where infection control measures have been heightened, that might counter the risk of contracting nosocomial pathogens as well. So you could see here, there are many pushing and pulling factors that we have to consider. Next slide, please. Now, those of you who know me might know that I am an avid knitter. So every time I look at that diagram that I just presented to you, I'm thinking, you know what, this is a tangled mess of yarn, and how can I turn it into a neat ball of yarn, and better yet, elevate it into a finished knitted sweater that I could wear with joy? So let's give it a go. Next slide, please. So I present to you the 3 rapid reviews that was done with the TARAN project team. TARAN is the Toronto Antimicrobial Resistance Research Network. The first paper was published in July last year. That was on the bacterial co-infection and secondary infection prevalence in patients with COVID-19. That was a rapid review with meta-analysis. The second paper was on antibiotic prescribing prevalence in patients with COVID-19. That was also a rapid review with meta-analysis that was published early in 2021. And the third and most recent publication is the predictors and microbiology of respiratory and bloodstream co-infections in patients with COVID-19. And this was a rapid review and meta-regression. Next slide, please. Now, in the interest of time for this session, I will be focusing on the third rapid review, but members of the audience who are interested in learning more about the first 2 papers, I would encourage you to check out a previous PHO Rounds recording that was done on May 27th, in which Brad and Val gave a fabulous presentation summarizing the findings of those 2 earlier papers. The results of the living review are also hosted on the TARAN website, and the links are provided on this slide. Next, please. So you could think of the 3 rapid reviews as a play with 3 acts. The first 2 are about bacterial co-infection and antibiotic use. And the third one, the objectives, were to describe the prevalence and microbiological characteristics, focusing on respiratory and bloodstream infections, as well as to identify predictors of bacterial infections at the study population level. Next slide, please. Let's talk about the methods that were used. There were some common inclusion criteria for the 3 rapid reviews, but there were also some unique inclusion criteria specific to the study objectives. For the third rapid review, we had focused on studies that indicated the number of patients with respiratory bacterial infection and/or bacteremia in their reporting. Next slide, please. We had a consistent search strategy. I think that one major difference is the time frame that captured the publication. I wanted to point out that the first rapid review, the search timeframe had gone up to April 16, 2020. For the second one was up to June the 9th, 2020, whereas the third one, the co-infection with meta-regression technique, captured publications up to the first week of February 2021. For each of those rapid reviews, we received very helpful advice and support from a medical information specialist. The search terms were quite similar, and all the protocols were registered with Prospero. Next slide, please. These are the primary analyses of the first two rapid reviews. The first one was stratified by co-infection, defined as infection that were evaluated on presentation, and secondary infections. These are bacterial infections that were identified during the course of the COVID illness, as well as stratification by severity of COVID-19. For the second review, the antibiotic prescribing, that was stratified by region of the study location, severity of COVID-19, the end month of the study completion, as well as age group. Next slide, please. For the third rapid review, focusing on respiratory and bloodstream infections with meta-regression, we stratified again by co-infection and secondary infection, but also stratified at the level of the study population's characteristics, specifically the healthcare setting, such as critical care versus ward level care versus outpatient, ventilatory support, patient demographics, the month end of the publication. And importantly, as the treatment of COVID-19 continued to change and evolve, we also looked at the effects of COVID-19 treatment as per current standard of care. Next slide, please. We reported the prevalence of patients with bacterial co-infections, secondary infections, and antibiotic prescribing. For the meta-regression to evaluate the association between patient characteristics at the level of the study population and risk of bacterial co-infection and secondary infections, we'd used univariable and multivariable models, and we reported odds ratios compared to a reference group. We had done the usual assessment of heterogeneity using I-squared statistic. We also took time to do the risk of bias assessment using a 10-item tool and classified the studies that were included as having low, moderate, or high risk of bias. We also conducted sensitivity analyses based on the risk of bias, as well as the testing methods for identifying bacterial infections, as well as whether the study investigators had a priori clinical definition of infection that they had used in describing patients with bacterial infections. Next slide, please. Let's look at the results. So just to recap, this is a very nice visual abstract for the first rapid review. At that time, we had 24 studies, over 3,300 patients, and the data capture was up to March of 2020. We found co-infection on presentation to be 3.5%, the prevalence, and for secondary infections was 14.3%. Antibiotic prescribing prevalence was just under 72%. Next slide, please. And this is a recap with the second rapid review. By then, we had more papers, so 154 studies were included, over 35,000 patients with COVID, and data collection of the COVID patients were up to May 2020. And here, focusing on antibiotic prescribing, we found that the prevalence of use was just under 75%, whereas the bacterial co-infection prevalence was 8.9%. Next slide, please. So for the third and most recent rapid review, more than 56,000 studies were initially identified, and with title and abstract screening and assessment of eligibility, we included 171 studies in the analyses. Next slide, please. We found that the majority of the studies included were retrospective in design, followed by a smaller percentage that were prospective cohorts and an even smaller number that were randomized controlled trials. In terms of study location, it was predominantly Europe, Asia, and North America, but we also had a very small number that were included that were from the Middle East, for example, and South America. As for study setting, general hospital admission was the most common, followed by intensive care and mixed setting. This time, there were 171 studies, over 171,000 patients, with the majority being men. Median age was 61 years, and a median of 25% were in the ICU, and median 21% required mechanical ventilation. The most common comorbidities were chronic respiratory diseases, cardiovascular diseases, and diabetes. Next slide, please. So this is the forest plot showing the prevalence of co-infection on presentation by healthcare setting. You could see that the overall prevalence was 5.1%, but there were some differences by setting, such that patients who were in the ICU had a prevalence of bacterial co-infection at 15.4%, whereas those being cared for in the outpatient setting was much lower at 1.9%. Next slide, please. This is the forest plot showing the prevalence of secondary infections stratified by healthcare settings. The overall prevalence was at 13.1%. But I think the most interesting part here was, as you could see, in the ICU subgroup, the prevalence of secondary infections was 41.9% compared to the general admission at 8.2% and the hospital outpatient mixed setting at 11.1%. Next slide, please. As for the organisms isolated, this is also very interesting finding. For the co-infection, 1,300 isolates were identified, and it was predominantly Staph aureus, followed by coagulase negative staphylococci. Whereas for secondary infection, it was much more diverse in terms of the types of pathogens, the species of pathogens that were identified. Although Staph aureus numerically was still the highest number of isolates identified, it was no longer in terms of the proportion, it was not as high as that in the co-infection. And with the diversity, we saw more gram-negatives that are common in the nosocomial setting, such as a higher number of Acinetobacter and Pseudomonas species being isolated, as well as Klebsiella, for example. For the gram-positive, Enterococci was also higher in terms of numbers and in proportion compared to the co-infection subgroup. Next slide, please. Looking at the results from the meta-regression to identify predictors, factors associated with bacterial infections, we found that studies with a higher proportion of ICU patients had higher odds of bacterial infections, and that included co-infection on presentation, as well as secondary infections, compared with the general admission and outpatient setting. And similarly, studies with a higher proportion of patients requiring mechanical ventilation also had higher odds of bacterial infections compared to studies with a lower proportion of patients on mechanical ventilation. We found that studies with a higher proportion of female patients had lower odds of secondary infections compared to those with a lower proportion of female patients. And interestingly, Immunotherapy, specifically corticosteroids and the interleukin-6 inhibitor, was not associated with a significantly higher odds of bacterial infections. Next slide, please. There are several strengths with this rapid review. We had a much larger number of studies included, and with that, the findings were actually very consistent with the two previous rapid reviews. We had a wider geographical representation than previous rapid reviews. And using the meta-regression technique, we're able to quantify the risks of co-infections and secondary infections based on patient factors at the study population level. I think the most important part is that this points to opportunities for antimicrobial stewardship. For example, knowing the high prevalence of secondary infections amongst patients with COVID who are in the ICU or on mechanical or requiring mechanical ventilation, perhaps this is an opportunity to collaborate with our infection prevention and control colleagues to tackle the high prevalence of nosocomial infections. Of course, there are limitations with this rapid review as well. There were quite a high heterogeneity amongst the studies. And we also identified that there was not a small proportion of studies with high risk or moderate risk of bias. And this was affecting the quality of the studies. There was also at times limited details provided describing the bacterial detection methods, as reported in the publications. There were also challenges in differentiating between the pathogens that are causing infection, contaminants versus colonizing organisms. And I think this is always going to be a problem in situations like this, especially when there are diagnostic difficulties, diagnostic challenges. We took at face value, as reported by the study's investigators, how they distinguished between primary and secondary infections, and that was according to their own definition as they reported it. Next slide, please. So this is a visual abstract summarizing what I just presented, the interesting results being the prevalence of bacterial co-infection, secondary infection in the different healthcare settings, as well as the odds ratio of infection amongst patients who are requiring mechanical ventilation and those who are in the ICU. Next slide, please. So this is members of the TARAN COVID bacterial co-infections project team. And as you can see, we have a very strong team, and this was a very interesting project. Next slide, please. And this is the list of references that I have used in my portion of the slides. And with that, I'll hand it over to Valerie.
Thanks, Miranda. Transitioning to this portion of the talk, Miranda has set us up very nicely to talk about what's really been happening with antibiotic stewardship during this time, and really thinking about how we might evaluate and assess what's happening after the pandemic, as well as, where there's opportunities for improvement. So as Miranda mentioned, there's opportunities for stewardship within the pandemic, specific to a relatively low rate of co-infection, bacterial co-infection in patients with COVID-19, and juxtaposed by quite a high rate of antibiotic use. So by way of background, antibiotic stewardship, here's the definition, and I'm sure many of you are very, very familiar with these types of interventions, which are really designed to improve and optimize antibiotic use. In general, stewardship programs are most well established in hospitals, although we know that stewardship activities in long-term care and primary care are also established in some places. Here at home in Canada and in Ontario, it's been a stewardship, has been a Accreditation Canada required organizational practice since 2013. And so the vast majority of hospitals providing inpatient acute care, cancer rehabilitation, and complex continuing care services will have a program in place. And that's what we'll really focus our discussion for the next part of the presentation, so specific to hospital programs. So throughout the pandemic, Mike Stevens in the US and his group have published a few papers really providing thought leadership around, what are the opportunities for ASP involvement in the pandemic response, and what are some of the maybe consequences or implications of that in the short and long term. And so what we really appreciated at PHO about this was following sort of the evolution of his group's thinking helped us to position how we might want to look at stewardship here in Ontario during and after the pandemic. So the first paper that was published by this group really was kind of thinking about where are some areas that naturally stewardship programs and hospitals could help support the pandemic response. And it's no surprise, right, with some of the existing collaborations and work with infection prevention and control, diagnostic stewardship, really trying to be good stewards of limited resources. So in early days, that would have been, for example, testing, and then a big part was, very obvious treatment, supporting the guideline development, dissemination, etc. At that time, it was very early in the pandemic, like, March-ish, March, April. That group pulled Twitter informally and revealed that, it was a pretty even split of about a third of ASPs were saying that they were having direct involvement in their organization's pandemic response. A third had indirect involvement, and a third had no involvement at that time. They also did a PubMed search of literature and really revealed there was very limited, basically none, speaking to this topic. And so, very early on in the pandemic, identified this as an area of interest. Later on in the pandemic, they also published a paper that talked about some of the core activities or core strategies and how they might be adapted to support the COVID-19 response. And I won't go through all of them here, but there's a very nice table within the paper that describes possible adaptations at that time, kind of the future thinking, as well as some potential adverse consequences on traditional ASP activities, knowing that resources, diverted away from traditional activities could impact, delivering those, and then as well as some hypothetical potential long-term implications. They're very interesting. I would encourage you to have a look at the paper and then I think some of you who have been in the field in the last year will recognize some of those ideas and may relate quite well to them. So, here's kind of some of the things they talked about. I'm just going to highlight a couple of them. Prospective audit and feedback, is it tends to be very resource intensive, but is a strategy that is the bread and butter of a lot of well-established mature programs. And so I'm going to talk a little bit about some of the potential adaptations they talked about. And then I also highlighted guidelines and clinical pathways, because I think we can all relate, looking back, that this was an area where stewardship programs and really contributed a lot of time and effort. And a couple of the papers that this group published, the authors described like their own experience in that, and that hundreds of hours were spent towards that. So I think just highlighting a couple of these, there's some overlap, right, with some of these strategies related to COVID, but just wanted to highlight those two. With prospective audit and feedback, so when we think of this strategy really is a formal assessment, or at least in the traditional sense, formal assessment of antimicrobial therapy by an antibiotic steward, who then makes recommendations to the prescriber when therapy is considered suboptimal. And as I mentioned, this tends to be a resource-intensive strategy, but also can be thought of as the bread and butter of a lot of well-established mature programs. So this would be something that's in place before the pandemic, and some of the sort of adaptations that Mike Stevens' group gave were really interesting, because started to highlight the sort of differences between what is more COVID focused and what was more antimicrobial use focused in terms of adaptation. And you'll see here, there's a few examples, but I think most of us in Ontario know that there was a lot of, workload around some of the investigational use agents that we used, such as remdesivir and tocilizumab. So, no surprise that a lot of programs may have adapted their prospective audit and feedback to try and facilitate that, to try and ensure appropriate use. And although it wasn't focused specifically on antimicrobial use, some of those programs may have incorporated adaptations that, incorporated review of non-antibiotic use agents. So you can see here, there's some examples they cite from the literature. These are kind of really dependent on how the program operated before, and as well as what was a priority of that organization. So really the question I think we're all wondering is, what is known so far about the impact of COVID-19 on involvement and activities of ASPs? On the one hand, it's kind of like the AMU, AMR question. We're not really totally sure about the directionality. So on the one hand, has ASP involvement in pandemic activities adversely impacted traditional ASP activities, diverting resources away from those, well-established things that stewardship programs were doing before the pandemic? Or on the other hand, has ASP involvement created opportunities to strengthen the program infrastructure and increase prominence beyond the pandemic? So these are questions I think we're very interested here at PHO. And I found a couple of examples in the literature, but prefacing it with the fact that these examples were mostly from the very early days of the pandemic. So data that's been collected, sort of May-ish 2020. So, there was an example of an Irish survey of ASP practitioners that, was a little bit subjective, asking, how they felt their stewardship program, how effective it was before and sort of during the pandemic on a scale of 1 to 10, that found that there was, a decrease in the score of that, as well, had a really nice table outlining some of the challenges that survey respondents describe, and really no surprise, lack of resources due to reallocation of resources for the response, really impact of IPAC restrictions on performing activities that traditionally were maybe in person, like rounds or audits, meaning prospective audit feedback, education committee meetings. So there was that kind of example where, people felt it was actually not as good. But then on the other hand, there was also an example that I found where in Singapore, there was a description of a program that maintained acceptance rates during the pandemic and saw the, decrease in broad spectrum antibiotic use and length of stay where interventions were accepted. Now, again, caveat being that these were studies that were conducted quite early in the pandemic. And, I think we all know that things have evolved over time, and, the answer may be different now. So having said all this, I think, our interest at PHO is, at a provincial level, what about stewardship programs in Ontario? And so the next few slides are going to be about what we know so far about it, and as well as, asking for your reflections and feedback on what other things we might highlight from the information that we have. So switching gears a little bit, I want to just, so Miranda's section had 3 acts, and so does mine. This part is about our Ontario ASP landscape survey. So this is a survey that PHO conducts every 2-ish years, really trying to understand the overall landscape of programs in Ontario hospitals. And every time we've done it, we've had a slightly different focus, and it has evolved over time for sure. So our first survey in 2016 really focused on what kind of structural and strategic elements were in place. And then in 2018, when we repeated the survey, we included elements about antimicrobial use and antimicrobial resistance. And then this year, we were supposed to do the survey in 2020. Of course, that got delayed. And I think at that time, we were quite disappointed. But in retrospect, having done the survey now, it actually gave us a very great opportunity to ask programs about not only their program structure and track some of those elements that we've been wanting to trend over time, but also get some insight on how they've been doing during the pandemic, and what some of the impact on those traditional ASP activities are. And as I mentioned before, that literature from Mike Stevens' group really helped to shape some of our questions and direct some of our analysis. So while I'm going to be presenting to you some preliminary findings, there will be more to come. So this is the structure of our 2021 survey, just so you have a sense of the kinds of different questions we asked. So I'll be talking to you a little bit about Part A and Part D, which talks about program structure and also COVID-19 impact on ASP activities. So just a few slides on methodology. In terms of the survey, it is a voluntary online survey. And this year we tried to find ideal timing and opened it in September and have actually extended it because we know everyone's so busy and we want to hear from as many Ontario hospitals as possible. So the data that I'm going to be presenting to you is preliminary, and I think I used a cutoff of early November. So there will be more data to come as the survey is still open. As we have done in previous years, it's distributed at a corporation level with instructions that it should be completed by the individual that is most responsible for stewardship. So really intending to obtain one response per corporation, unless for some reason the organization wants to submit separate site-specific responses. There are a few, but the vast majority of our respondents usually describe their program at a corporate level. So we have a targeted distribution list, and this year, we knew people were really busy, so we had targeted email invitation with email and telephone reminders to encourage response. And thanks to all those that took my phone calls, Brad and I's phone calls, to encourage you to respond. We really appreciate you making time to do the survey. We also offered a nominal incentive this year for participation, which we didn't have in previous years. And so, as I mentioned, this is a preliminary cut of the data. I used a cutoff of November 2nd, but we know that there's quite a few responses after that time, and it's still open. In terms of just incomplete responses, we included them. One thing to note is that although I mentioned there's 4 parts to the survey, we want any and all information. So if an organization doesn't have AMR or AMU data, that's fine for us, and we still encourage response, and we accept those and include those in analysis. So, it's possible and quite possible that a corporation may just respond to part A and D or some parts of it, and that we adjust the denominator for that. As I mentioned with Accreditation Canada, there are certain types of institutions that are subject to the required organizational practice of having a stewardship program. And so sites that are not one of those types, for example, mental health, ambulatory, independent, are excluded from our denominators for that reason. And lastly, in addition to sort of an overall analysis, we tend to describe as well the results using hospital type. And so you'll see here listed the sort of 4 main hospital types that we use. So acute teaching, large community, small community, CCC, and rehab. This is actually based on Ontario Hospital Association classification. And we also use like a ministry list that is associated with patient safety reporting to determine the denominator and hospital classification. But this is a classification that's based on usually at the corporation level. So just to note, we've got questions in the past where if there's more than one site at a hospital, it typically is classified by the largest type. That is just the way it is done at the ministry level, and we follow that. In some rare circumstances, especially when mergers happened later or more recently, sometimes sites retain their classification. But anyways, I guess overall what I'm trying to say is that the type is based on the largest site within that corporation typically. So here's a comparison of the response rates so far. So we think that this year, although I'm presenting response rate of 62% here, the final will likely be greater than 70%, and hoping that it'll actually surpass our 2016 response rate. So huge thanks to everyone who's responded so far. There's a slight change in denominator over time as a result of changes in corporate structure, so mergers and alliances, and again, we use a ministry list to reconcile that. With respect to the response rate, I just want to give you a brief breakdown here of the different types. Typically, we've had over time a lower response rate from small community, and that seems to be the case this year, but hoping that all of these will go up after we have closed the survey on November 30th. In terms of formalization of ASP, we asked this question to say, whether or not your corporation has a formal ASP. And again, it's pretty stable over time. The yes in progress is, sitting right at almost 100%, with just a few that say no. So that seems very, very unchanged, basically, from 2018. This question is about ASPs with designated funding and resources. And this is a question that has there's a lot of data behind this, but just at a high level, we ask whether or not you have designated funding or resources, whether or not, irrespective if you have actually FTEs. So, this again looks like very similar to 2018 with just over half saying that they do have designated funding resources. And we'll definitely be delving into the data a little bit more with our final analysis on this, including giving some insights about the FTE allocations for those who have FTEs assigned to their ASPs. Okay, so that was part A, just to give you a lay of the land, that basically ASPs aren't changed too much from 2018 as far as we can tell. And then now this next part is talking about, what have ASPs been involved in during the pandemic? And these are preliminary insights that I can share with you today. So these following questions really only apply to hospitals with a formalized ASP or in the process of formalizing. So the vast majority, I think there was 3 that said no. So that's kind of the denominator we're dealing with. The time frame for these questions we asked, we gave a time frame pretty wide, but March 2020 to fall 2021. So really up until the present time. We asked whether there was any FTE or designated resources change in that during the pandemic, and you'll see here 83% said there was no change in the amount of FTE or a full-time equivalents dedicated to the ASP during the time frame. The remainder, the other 17%, all except one said that it was decreased. So maybe not formally decreased, but sometimes people's resources were stretched and people were reassigned, etc. There was actually one case where there was an increase in pharmacist FTE, which was interesting. The survey also asked whether the ASP, specifically the stewardship program, was involved in specific pandemic-related activities, and whether or not specific core activities that were implemented before the pandemic were continued, modified, or suspended. And I just want to mention here that the next few slides give very high-level summary of the results, but the respondents, many of them provided a lot of free text comments and rich insights through that, and we haven't had a chance to analyze that, but hope that we can include that in our final analysis. So here's a breakdown of whether or not ASPs were involved in assessment of patients with COVID-19. And you see here's a pretty even split. So 50% assessed all or some COVID-19 patients, either as part of a targeted assessment or as part of their regular ASP duties, whereas the other half didn't, or said it was not applicable, maybe because they weren't admitting patients with COVID at their site. And then here's a high-level overview of the types of response preparation activities that ASPs in Ontario have been involved in. So I think I mentioned earlier that guideline pathway development really came out in the literature as well as being very time consuming and a high priority. So you'll see here more than half of programs were involved in that, either local guideline development, but also curation of guidelines, dissemination. Many people talked about dissemination and integration of Ontario Science Table recommendations, and as well there's some overlap between that and some of the other things about investigational use drugs. So again, as I mentioned, tocilizumab and remdesivir took a lot of time to organize, and this kind of was the theme throughout many of these different types of activities. With respect to the second highest thing, over 40% were managing drug shortages, particularly IV antibiotics early in the pandemic, and as I mentioned, tocilizumab and remdesivir, and then a smattering of other activities. But I think overall, what I sort of gleaned from this was that really Ontario hospital ASPs have made very significant contributions to pandemic preparation and response activities. And we should appreciate, that this is in the face of, trying to maintain some of their other activities, and often, being reallocated to help with some of these other activities. This is a slide that talks about some of those core activities that I mentioned before, that, the literature describes as sort of possible for adaptation in the face of COVID. And really interesting was that, so this slide only provides results related to ASPs that have already implemented this strategy before the pandemic. So if you already had prospective audit and feedback before the pandemic, then you were included here. But if you never had implemented it, that you're not included in the denominator. Okay, so that's something to keep in mind. But you know, over 90% of ASPs continued with de-escalation and streamlining. So this is great news because, as Miranda mentioned in her portion of the talk, you know, there's a lot of empiric antibiotic use in patients with COVID, and it's nice to see that, you know, programs in Ontario continue to do this kind of activity, hopefully to mitigate some of the, you know, consequences that we were discussing earlier with respect to, you know, inappropriate antibiotic use or overuse. The other thing to note here is that some of the other interventions like IV to PO step down, formula restriction, and scheduled antibiotic reassessment seem to be maintained quite well, and you know, with very few places saying that they modified or suspended. But the two where I think it's a very obvious as well, like why this would be prescriber education and prospective audit and feedback. You know, over 50% of them continued, but quite a few did talk about modifications or even suspending this activity. And that makes a lot of sense because typically prospective audit and feedback, as I mentioned, is very resource intensive, and prescriber education, you know, I think a lot of us know that that was typically done in person. And although there was remote options, a lot of respondents talked about, you know, there was reduced opportunity, people were very busy, and even with remote or virtual options, participation tended to be affected by that. So, you know, I think there's a lot more to know about these with them, you know, especially delving into the modification buckets. And as I mentioned, a lot of the free text we haven't had a chance to analyze. So we'll hope we can come back to you with more information about exactly how things were modified, as well as, you know, maybe some comments from respondents about what they think about long-term impacts. So in summary, I just wanted to mention that the number, as I said, of organizations with formal programs and designated resources appears to be stable and similar to 2018, based on the preliminary analysis of our survey. Despite very minimal changes in designated resources and funding during the pandemic, ASPs in Ontario have made huge, significant contributions to supporting the response while attempting to maintain core activities. And so the final analysis is pending and will also include antimicrobial use and antimicrobial resistance. If you're an organization that hasn't had a chance to respond, it's not too late. So please contact us and we will send you the materials, the link, and so forth. I wanted to just ask the audience at this point too, as they think about questions, whether there's particular questions about what I've talked about, which we could potentially answer from the data as we look through the free text. I'd be interested to know your thoughts. And finally, for those of you who are familiar with the ASP comparison tool, which is an online interactive tool, that integration of these new survey results for the organizations that opted in is targeted for March. And we are currently working very hard to upgrade the tool features right now. So with that, I will turn it back over to Brad for any questions and comments.
Great. Awesome. Thanks so much, Val and Miranda. That was a great presentation. We do have some time for questions. Please type your questions into the Q&A pod at the bottom of the screen and we'll try to get to them. But as people are typing their questions, maybe I'll get started. I guess this question could be to either Miranda or to Valerie. We talked a little bit about how antimicrobials are overused in patients with COVID-19. Do you have any practical advice that you would give to antimicrobial stewards that are looking to improve antibiotic use in patients with COVID-19? In particular, any references or resources that you can refer clinicians to?
Maybe I'll take a stab at answering this question. So I think right now, cumulatively, the data have shown that bacterial co-infection on presentation with COVID is actually fairly low. So far, a lot of the local, national, and international guidelines have updated to reflect this. So I would always, suggest clinicians to, look at those and think about, whether there are ways that we could reduce empirical antibiotic use. And I think that might be one way to mitigate that. And, explain why, how things have changed from the start of the pandemic until now, and use that as a resource.
Yeah, I agree with that. And as I mentioned, it is very hard at the beginning sometimes to differentiate right between the two. But as we saw with the survey results, a lot of programs in hospital continue to do those traditional activities that really impact and decrease inappropriate use. That streamlining de-escalation reassessment piece is really important. And I think, balancing that with what Miranda said, not to start maybe antibiotics in the first place, but also then reassessing and de-escalating when feasible.
That's great. Thanks so much. Thinking kind of along those lines to stewardship from the perspective of patients who don't have COVID-19. As you've mentioned, Val, like resources have been stretched quite thin for a lot of antimicrobial stewardship programs. So do you have any thoughts or advice about how antimicrobial stewardship programs can continue to operate, at least to the full extent of their ability, in the context of such limited resources?
Yeah, I think that's a difficult question. Certainly, like a lot of programs have said in their responses that they are using more technology in terms of like maybe even obviously virtual rounds or that kind of thing to really minimize having to go on the unit, but also to maybe reach people in different locations if they've been redeployed or what have you. So there's that piece. There's also actually a fair number of organizations also said that they upgraded their CPOE or their inpatient electronic records, and I don't know if that's good or bad. I think there's growing pains with that, and we definitely heard about some of those growing pains trying to let us know that they couldn't submit, for example, AMU data this year, but probably with some of those advances that there's certain maybe interventions that could be automated, or lists, patient lists could be generated with a little bit more risk stratification, etc. So I think I think it's a hard question to answer, but those are some of the things we've been hearing from the field.
Thank you. We have a few questions in the chat pod. The first question is, do we have any data from the federal, provincial, and territorial level to compare as we progress towards the fourth and fifth wave of the pandemic? I'm guessing this means antimicrobial use or resistance data.
I think with antimicrobial use data, so Brad, you can maybe add to this, but in terms of our survey, we collect that from hospitals who are able to provide it. In Ontario, there is no comprehensive system that collects hospital antimicrobial use. So that's why we do the survey and try and get that from a hospital level. I don't know that we have comparison from other provinces or and we do have some national data, but it's not really at that same level. I should also mention that the AMU data we collect is all antimicrobials, either DDD or DOTs, on an annual basis, stratified sort of by quarter. So it is quite high level, and I'm not aware that we have very good direct comparison for that. I don't know, Brad, if you had any other thoughts around that.
Yeah, I would totally agree. I think that's an opportunity, not just in the context of COVID, but just going forward, is having consistent access to data and comparable data across not only Ontario, but Canada. So that's definitely an opportunity for growth. We do have time for one more question. It's what methods would you suggest to optimize local uptake of COVID guidelines at the hospital level that are developed by the Ontario Science Table? For example, not initiating antibiotics up front and the use of tocilizumab. Maybe I'll pose this one to Miranda if you want to take a first stab at it.
Thank you. I think a lot of it was awareness of what is recommended in the science table, and then of course a lot of things keep changing. The literature, the publication keeps changing, but I think the consistent message, through as shown in our 3 successive rapid reviews, that the co-infection is low. I think that is I think that gives me confidence to try to persuade prescribers that, you know, it is not the go-to empirical antibiotics, and, you know, point towards the Ontario guidelines, which is also updated to reflect new information. As for the adverse effects from IL-6 inhibitors such as tocilizumab, I think that is kind of a bit more complex because there's also patient factors that we need to consider. And I would, again, try to collect some local data and maybe use that to persuade clinicians to be vigilant in assessing the risk of secondary infections, but at the same time, try not to be turning towards empirical prescribing if they can. I know there are diagnostic challenges, and I don't know if we could resolve those within the fourth wave.
Thanks so much, Miranda. So I think that's time for us. It's just past 3 p.m. So I'd really like to thank Val and Miranda for presenting. And I also want to thank everyone for joining today's session. Some really great questions. So you can expect to receive a brief and anonymous PHO Rounds survey. Please try to complete this. It will help us to improve our future programming. And lastly, if you want to access PHO Rounds, this rounds or any other rounds, you can head to the PHO website under Education and Events and click on Presentations. So thanks everyone and have a great day.